Hello, my name is Lauren Wuffer, and for week 3, I have chosen the topic of hyperkalemia. The pathophysiology of hyperkalemia there are 3 major causes. First being decreased renal elimination, secondly, excessive rapid administration of potassium, and 3, the movement of potassium from intracellular fluid to extracellular fluid spaces. It is important to note that the impact that aldosterone plays in hyperkalemia. Aldosterone acts in the distal tubule of the sodium-potassium exchange system to increase potassium excretion and reabsorb sodium. Disruption in the aldosterone secretion can lead to hyperkalemia. A few other conditions can cause potassium to enter the extracellular fluid. For example, tissue injuries cause the release of potassium into the extracellular fluid. Burns and crush injuries cause cellular death, thus causing release of potassium into the extracellular fluid. Clinical manifestations include lab values such as a serum potassium level greater than 5 milliequivalents, an increase in the baseline serum creatinine, an increase in the BUN, and a GFR less than 5 milliliters a minute. Physical symptoms are paresthesia, described as numbness or the pins and needles feeling, complaints of muscle weakness. Patients with hyperkalemia require an electrocardiogram or ECG monitoring for electrical changes, specifically a peaked and narrow T wave, a wide QRS. As the hyperkalemia progresses, the PR interval lengthens, followed by an absent P wave and a slower heart rate, eventually leading to ventricular fibrillation and cardiac arrest. Treatments include IV push calcium chloride, administration of IV push insulin and dextrose. Note that this is a temporary fix of the hyperkalemia as it pushes potassium back into the intracellular fluid. Administration of a loop or thiazide diuretic. This allows for potassium to be excreted through urination. Hemodialysis removes excessive potassium from the extracellular fluid, identifying the underlying cause of the hyperkalemia. You could also hold potassium-sparing diuretics such as spironolactone, holding ACE inhibitors and ARBs due to their effect on decreasing the aldosterone levels. And patients who are receiving any type of treatment for hyperkalemia should be placed on a heart monitor out of an abundance of caution. Thank you.